Hello, everyone, and thank you for tuning in to another episode of the Oncology Brothers podcast. I'm Rahul Gosain here with my brother and co-host, Rohit Gosain. And today we're tackling myeloproliferative neoplasm. Our focus today is going to be on Polycythemia vera and essential thrombocythemia. These patients often show up in our community practice as a referral for abnormal labs, and risk assessment and targeted management for these patients is critical. To help us break down MPN in 2025, we're thrilled to welcome Dr. Andrew Kuykendall, a hematologist specializing in MPN from Moffitt Cancer Center, and he was also the recent ASCO plenary presenter for Verify study on Polycythemia vera. Andrew, welcome.
Andrew, thanks so much for joining us. Let's start off with PV. In community settings, we see these patients, particularly for erythrocytosis, where we have to rule out the secondary causes of erythrocytosis. That is obstructive sleep apnea, someone living at a higher altitude, smoking, or prior lung resection, and the primary cause of bone marrow disorder, that is MPN. Can you walk us through your updated workup for suspected PV today? What is absolutely essential? And are you getting JAK2 and EPO level upfront for all these patients? What is the utility of bone marrow biopsy and testing for CALR, MPO for PV, especially when they're rarely seen in this setting and commonly seen in ET?
Yeah, we get a good amount of referrals for erythrocytosis, and a lot of times we're seeing the patients to make sure they don't have polycythemia vera. That's the main reason they're coming to see us. Fortunately, with the advent of understanding the JAK2 mutation is present in the vast majority, 95% or more of these patients, I think that's really helpful to get objective evidence. But I think you still sit down with the patient and talk about symptoms they've been having. A lot of times you'll find out that maybe they have itching symptoms or sweating symptoms, or maybe they've had fatigue that started 3 to 4 years previously. That always raises your suspicion that this might be something more than just erythrocytosis. But the first thing we do is look at the blood counts. You look at iron levels too. Certainly if their white blood cell counts, their platelets are elevated in conjunction with the erythrocytosis, that clues you in that this could be something driven by the bone marrow. The EPO level is really helpful and can streamline that conversation. Previously I would have said that we do get JAK2 mutation testing on most patients that are coming to us with erythrocytosis, but ideally this could be done as a reflex after the EPO level is done. If you have someone who comes in and you're not suspecting polycythemia vera and you have an EPO level that's kind of normal or even a little bit elevated, the JAK2 test probably doesn't need to be done in that patient. Certainly a bone marrow probably doesn't need to be done, especially if you have a good other secondary cause. So I think those are a few things that I'll do. The bone marrow biopsy I will get in most patients with polycythemia vera, but I typically will wait to see the JAK2 mutation being positive. Once that's positive, then I'll drive it, because I often tell patients it doesn't hurt me at all for them to get a bone marrow biopsy, but it's not something that's necessarily super comfortable or super enlightening if we really are not suspecting that is the case. I do want to highlight a couple of causes. You mentioned a few for secondary erythrocytosis. Anything that's cardiac abnormalities, lung abnormalities, smoking, sleep apnea, emphysema, people who have had prior lung resections. We've seen, you go back and find that they had a wedge resection for some sort of granuloma or early stage lung cancer. But one that's really common recently has been patients that are on SGLT2 inhibitors. Those cause erythrocytosis, and they're being frequently used for patients with diabetes or even pre-diabetes. Seema Gang from Mayo has a couple articles showing that those do raise hematocrit quite noticeably. I think that's one thing we're increasingly seeing is referrals for erythrocytosis, and we find out that it really did start when they started these SGLT2 inhibitors. I think that's a helpful one as well.
Andrew, once you've excluded secondary causes, in my practice, I've not done bone marrow biopsy on every single patient I do get that JAK2. Once that's confirmed, we're saying this is PV. Next up here ends up being risk stratifying these patients, which is based on their age, history of thrombosis. Can you touch on your treatment paradigm here? And does the type 2 JAK2 mutation matter? If it's V617F or exon 12, what can we expect in terms of symptom improvement with our treatment options today?
Historically, the treatment paradigm has been lumping people into kind of high risk versus low risk. High risk being, are you over 60 years old? Do you have a prior history of a thromboembolic event? About 60% or so of patients are going to be high risk. A lot of them are going to be by age, right? Because the median age of diagnosis is just over 60 in this group of patients. The rest, if they don't, if they're younger than 60, they don't have a history of thromboembolic disease, those patients will be low risk. Historically, we've said for every patient, we're doing a baby aspirin once daily from the ECLAP study that showed the benefit of that, and phlebotomizing to maintain a hematocrit less than 45%. That comes from the Cyto PV study, which confirmed findings from the 70s that suggest keeping the hematocrit less than 45% was protective. In high-risk patients, in addition to that, we'll add on cytoreductive therapy, which is hydroxyurea, interferon formulations, or in the second-line setting, Ruxolitinib is approved. I think it's not as black and white as that. There's certainly a lot of art that goes into this. My personal qualm is that if you just treat based on that, you'll never prevent a young patient from having their first thromboembolic event if you decide not to give them cytoreductive therapy. And we do know that there's probably some factors that would make patients who are quote, low risk, maybe a little bit higher risk, higher JAK2 allele burden. If they have a frequent need for phlebotomy where they're getting this maybe every couple of weeks, every month, it's really challenging, high white blood cell counts, and some other disease-related symptoms, sweats, fever, night sweats, may make me think about starting cytoreductive therapy earlier on. Historically, we wanted to avoid that because we didn't think or know that any of our treatments had disease-modifying potential. But now I think with interferons, we're seeing that there is a consistent ability of interferon formulations, whether it's pegylated interferon or ropeg, to reduce that variant allele fraction over time. Do we know exactly what that means? No, but it does seem to be moving in the right direction. When we think about that these patients, especially young ones, are at risk for this progressing to myelofibrosis, that is something we certainly discuss with patients. We get a lot of motivated patients who come in saying, I'd like to be on interferon because I want to kind of get ahead of this. And you have to kind of talk about the pros and cons, maybe the lack of data, but also the potential. And that's where we have this shared decision making. The higher risk patients were much more insistent that we need to be on some sort of cytoreductive therapy for an added layer of protection. The nice thing is you have a lot of options and they're all very different. So hydroxyurea, it's a pill, it's cheap, it's easy. There's a lot of comfort with giving it. It's hard to get away from that because it is comfortable and there's not a ton of data that would say something is better than that, right? As much as we have data that suggests benefits to interferon formulations, it's hard to say that interferons are conclusively better than hydroxyurea. Although when you get into the motivations of patients, that might make more sense for certain patients than others. Both hydroxyurea and interferon can control blood counts quite effectively. About 12 months into treatment, multiple studies have shown they're pretty equal in controlling blood counts. But from a symptom standpoint, they may help with some of the symptoms, but they're largely ineffective in improving symptoms of the disease. And I think that could be quite frustrating, especially when we're talking about itching, the fatigue that comes with Polycythemia Vera, some of the constitutional symptoms that are more rare, those don't really get improved significantly with those two agents. And that's where Ruxolitinib in the second line, I think, has certainly a benefit for patients that are highly symptomatic, especially constitutional symptoms and itching. That's where Ruxolitinib really can play in, provide a huge benefit for patients.
Andrew, thanks so much for summarizing your treatment paradigm there. In our day-to-day clinical practice, we still rely heavily on phlebotomy and hydroxyurea. If phlebotomy in high-risk patients is keeping things well under control, then is there utility for adding hydroxyurea or other cytoreductive agents here or chasing the disease course?
So in the high-risk population, I would say yes. Mainly this comes from studies done in the 70s that looked at patients. This was when they were doing the PVSG study, the Polycythemia Vera study group. The first study looked at multiple types of chemotherapy versus phlebotomy alone in PV patients. It turned out giving chemotherapy is not a good idea. Those patients are much more likely to get secondary leukemias. But the patients who were getting phlebotomy alone had a high rate of thrombotic events, 36% over about 6 years. The chemo-treated patients actually had fewer thrombotic events. So the thought was, okay, maybe we shouldn't give chemo that gives patients secondary leukemias, but maybe we do need to cytoreduce patients. And that's where hydroxyurea, which was looked at later on a single-arm study, but then compared retrospectively to the therapeutic phlebotomy arm, showed that it was able to really minimize that risk for thrombosis. We also extrapolate from ET, where hydroxyurea has a randomized trial showing a decreased rate of cardiovascular events. I think phlebotomy can be helpful, but it's almost like it's like the inverse of giving blood transfusions. So in patients that have MDS and need blood transfusions, you're going to give them that transfusion, but you'd love to have an agent that could actually prevent them from needing those more consistently. And it's probably beyond just blood count control, right? There's mechanisms of hydroxyurea that are beyond just controlling blood counts. There's probably impacts that it has on blood vessel elasticity, flexibility, and things like that allow it to be further protective on top of adequate blood count control.
Absolutely. Andrew, before we switch to ET, can I push you a little more on how are you picking that cytoreductive therapy between hydroxyurea, interferon, and then when you're switching it to ruxolitinib? Is it that splenomegaly that you're saying that I can reduce their size for the spleen using ruxolitinib? Also, if you don't mind touching on some of the side effects, you mentioned PV comes with fatigue. All these medications have that overlapping symptom of fatigue.
Yeah, so it's easy and hard at the same time to pick between these because they're very different agents. There's not too many of them. We have the benefit of sitting down with patients and kind of I'll list off pros and cons of each one. My biggest thing is interferon is probably has the highest upside, right? As far as the ability to reduce JAK2 allele burdens, even in a minority of patients, it may be able to achieve molecular remissions, the allele burden going under 5% or 10%. I think that, if you have someone that can tolerate an interferon formulation long-term, achieve these lower JAK2 allele burdens, I think that's a huge upside. The downside is subcutaneous injection given weekly, broad side effect profile. Expense and cost is very unpredictable with some of these agents. They can be quite affordable to some and others maybe not. In younger patients, I tend to favor interferon formulations if they don't have any red flags. Mood disorders, history of autoimmune diseases would be reasons not to go down that route. The side effect profile, I'd rather start with something that has the highest upside and then switch off if we realize we can't tolerate it. In older patients where disease progression occurs over decades, hydroxyurea is perfectly fine. Now, where you draw the line between young and old is very controversial. You can get into that conversation with the patient, just understand their goals. And then you meet the patient who's like, can't take showers because they're itching so bad. And so you're like, okay, that's the person that needs ruxolitinib. And they're going to likely benefit from those inflammatory symptoms. From a side effect profile, all of these are extremely well tolerated in the big scheme of things. PV patients, chronic myeloproliferative neoplasm patients, do not accept side effects, right? They're living the disease for 10, 20 years, and we want them to live a normal life. Hydroxyurea, the main one we talk about is mucocutaneous side effects. Maybe mouth ulcers, very rarely these weird ankle ulcers that happen in less than 5% of patients. That would be a reason to discontinue. You can get some nail changes, some hair changes, some fatigue. A lot of the side effects of hydroxyurea are at higher doses. So if you can maintain 500 daily or 500 BIDs, you don't really run into many of those. Rarely, some patients with hydroxyurea will get fevers whenever you introduce them to the agent. That's a weird side effect, but it happens at around 3 to 5% of patients. And there is maybe some GI side effects in some specific patients. Interferon, we mentioned the autoimmune and mood disorders. And then ruxolitinib, early on, other than blood count, not too much with side effects. 3 long-term side effects: weight gain, non-melanoma skin cancers, and increased risk of shingles reactivation. The nice thing is those are longer-term things, so you can see if a patient's had fantastic symptomatic benefit. Often those things are less important if you've had an amazing symptomatic benefit from the agent.
Thanks so much for touching on that, Andrew. With regards to hydroxyurea, how far you push on the dose? 1,000 milligram BID, 1,500?
If patients aren't tolerating, I'm not going to push any further, especially when it comes to controlling certain blood counts like platelets. The value of controlling platelets is maybe a bit overblown. And I think that some patients we push to like intolerable levels of medications to try to control platelets. In general, I'm getting up to 1,500 milligrams daily of hydroxyurea. That's an area where I don't really want to push beyond. The old ELN criteria defined intolerance or resistance as being up to 2 grams. I rarely get to 2 grams a day in these patients. Typically 1,000 milligrams or less. I do have some patients where they're kind of alternating 1,000 and 1,500, and they seem to tolerate it just fine. You kind of go by tolerability. Once you're getting to that 1.5 grams, tough.
And with regards to fatigue that we were talking about, that's tied in with the MPN as well as these agents, iron deficiency we also encounter, especially when we are phlebotomizing these patients. How aggressive are you with repleting iron stores here?
Yeah, it's a tricky question because you're using up your iron to make these red blood cells. Most patients with PV, when they present, they're iron deficient. Oftentimes that's a clue that they have it. They show up and their ferritin's 20 or 15, and you're like, and then maybe they have a little bit of microcytosis along with that. At the same time, iron deficiency causes its own symptoms, even in the absence of anemia. And I think that's something that we're coming to grips with more. Previously, we would phlebotomize patients and make them more profoundly iron deficient. Then, we wouldn't need so many phlebotomies because they couldn't make a red blood cell because they had so much iron deficiency. And we're like, this is a success. Like we're winning. And the patient's like fatigued and has nail changes and hair changes, like doesn't feel like I'm winning. And so I think that you really have to remember that the iron deficiency has these symptoms. So if you're talking to a patient and they realize they're having kind of like restless leg, ice craving, fatigue, then we sometimes will do gentle iron replacement. The problem is it's pretty ineffective. because they rapidly take that iron and just make more red blood cells. And I don't think it gets where it needs to go necessarily. Some patients we have on low dose oral iron, or we've even given very gentle IV iron replacement. That's extremely rare. Probably a better solution is just that's when you start a cytoreductive therapy to eliminate that need for phlebotomy, so you're not exacerbating that iron deficiency. And we've seen that with all of these agents, right? Whether it's interferon or ruxolitinib, and we can talk about, rusfertide, the development of that agent. If you control patients' need for phlebotomies, you allow those iron stores to build back up. I think that does improve symptoms.
Actually, Andrew, this is a good segue, and then I promise we'll jump to ET, if you don't mind touching briefly on your ASCO plenary Verify study and the role of rusfertide in PV. It's not approved yet, but where do we stand today?
Yeah, so rusfertide, we've been involved in the development for a while. It's an interesting concept, and it speaks to a niche population of PV patients that have a continued need for phlebotomy and other symptoms associated with it, whether it's fatigue or poor tolerability of phlebotomy. And I think it stems from the fact that, if you try to explain to someone who knows nothing about medicine the modern approach to how we treat polycythemia vera, and you're like, well, we just bring them in and we bleed them a little bit. We take blood, and we do that regularly. They don't feel great with it, but we do that over and over. They're like, are we talking about modern day medicine, or are we talking about 1600s? And so I think that the idea was, can we have an alternative to that? And that's where understanding the hepcidin pathway and how hepcidin modulates iron regulation. I never thought I'd have to remember that after med school, but turns out it's a very druggable pathway. And that may be relevant for myelofibrosis as well and other anemic states. But the idea is that hepcidin is lower in patients that have iron deficiency. You're trying to rapidly, send iron to tissues that need it. The problem is in PV, you're iron deficient and making too many red blood cells. So all the iron that comes in is sent into circulation to the bone marrow. Rusfertide's a hepcidin mimetic, which mimics hepcidin and mimics a high hepcidin state. So it kind of restricts iron delivery to the bone marrow. And in the phase 2 study, we realized that it was quite effective at taking patients who needed phlebotomy and making them not need phlebotomy, regardless if they were on other agents for their PV. Seeing a lot of those patients on the phase 2, you felt like it actually improved their overall symptoms, their autonomy, and the ability to not be tied to the healthcare system. It's hard on a phase 2 study to look at symptoms because everyone's on the drug, and so you can't really rely on that. But they did have an interesting portion of that phase 2 that was a blinded withdrawal. You got a sense that maybe symptoms did improve. But on the phase 3 study, a blinded study, patients were randomized to either rusfertide versus placebo in addition to whatever they were already receiving. So most of these patients are already on hydroxyurea or interferon. That wasn't stopped. So they continued exactly what they were doing. And we looked at them over 32 weeks, and the study met all of its primary and key secondary endpoints. It decreased the need for phlebotomies, controlled hematocrit better without the need for those phlebotomies, and actually hit on these key symptoms. So patient-reported outcomes with fatigue and MPN symptoms were statistically better in the treated patients than the placebo, something that could be a benefit to patients who are not optimally treated with the current things we have, whether they're still getting phlebotomies, they don't tolerate phlebotomies, they're having a lot of fatigue with their current therapies. I think it's something that can add to our armamentarium and improve quality of life.
Absolutely. We'll look forward for this drug being approved. All right, switching gears to ET, we started off by saying that in PV, majority of our patients are JAK2 positive. But for ET, we should be looking for CALR, MPL, and that small subset of triple negative. Andrew, your work up here and risk stratification for this subset of patient population.
Yeah, so workup very similar to polycythemia vera with essential thrombocythemia, where usually these patients are coming in, they have high platelets. You're looking at their other blood counts. You're asking, is there any other reason why someone might have high platelets? It's a pretty broad differential, but I would say there's a few things that are more common. Iron deficiency, that's the biggest one. It's something that you can easily check with iron studies, looking at microcytosis, RDW, things like that can give you a clue in on the CBC that something else is going on. But the molecular tools are very helpful. 95% of these patients will have some JAK2, MPL, or CALR mutation. JAK2 is going to be the most common, 60%. Calreticulin or CALR, around 30%, MPL for maybe 5 to 7%. Mm-hmm. So that does help. Bone marrow biopsies here, I do recommend them for the most part because I think there are some things that can mimic. And certainly, it's tough sometimes to tease out ET versus pre-fibrotic myelofibrosis or primary. I think the bone marrow biopsy can be enlightening and helps to counsel patients on what to expect long-term with the disease. It may serve as a baseline. If you have to do one 5-10 years down the road, you can say, oh, we saw some fibrosis in there actually at baseline. This is not much changed. From a risk status, once you get the diagnosis, kind of a risk stratification, very similar to PV, but now you have an extra variable because not everyone has the JAK2 mutation, and that's more thrombogenic. Patients that have a JAK2 mutation who are older than 60, they're high risk. Patients that had a prior thrombosis, whether they're JAK2 or whatever, they're going to be high risk. Patients that are, CALR, who've never had a thrombosis and they're young, they're in this very low risk category, which is a nice place to be. Everywhere in between is this low or intermediate risk group that I'm not sure you can really differentiate between. They all fall in this kind of middle group there, where you're going to talk with patients about pros and cons of different options.
And with regards to the treatment paradigm here, Andrew, especially with aspirin QD, BID, and which ones are you relying on, hydroxyurea versus interferon? And also, we run into this issue of acquired von Willebrand disease. Which are those patients you're checking this before considering aspirin?
Yeah, for acquired von Willebrand's, we know it's a platelet-dependent phenomenon, tends to happen at higher platelet counts. So we'll definitely check it as a reflex in anyone whose platelets are over 1 million. If someone is dealing with easy bleeding, prolonged epistaxis, or heavy periods, or something like that, we may check this as well, just because we know it's something that can run with the disease. There's probably nothing special about 1 million platelets that turns it on or off, but you are more concerned at higher platelet counts. As far as frequency of aspirin, I don't have a big preference on one or the other. I think aspirin can be a good symptomatic medication in patients dealing with neurovascular symptoms, whether it's ringing in the ears, numbness, or tingling in the fingers like paresthesias, or frequent migraines. Sometimes BID aspirin does help. There's some data from the Italians that maybe it inhibits thromboxane synthesis a bit more if you do it BID. Overall, I think being on aspirin tends to help and can be done more frequently if patients have those types of symptoms. I think when it comes to goals of the aspirin, I think is kind of dual. I mean, we have better prospective data for aspirin than antithrombotic status in PV, but we extrapolate that a little bit to ET, but probably more of a role for aspirin as a symptomatic medication in ET. If they're on a DOAC, then I avoid the aspirin. If someone's on a DOAC, they don't need to be on both. And we do have longer term studies that have shown that if you're on both, it increases bleeding risk and doesn't really offer much protective benefit. There's unique cases, people with real bad peripheral vascular disease, or their vascular surgeon or cardiologist is recommending dual. Fine, yeah, that's good. But as a rule, I think if they're on DOAC for AFib, I won't add on a baby aspirin.
Andrew, our treatment options here, is there that magical number? You had touched on this previously when we were talking about PV. Are we chasing that 450, 400,000, or is this made up number and we should be chasing symptoms here?
As far as treatment goals, it's a phenomenal question. And I think it's something we're going to have to grapple with as we develop drugs in this space, because we're not really sure what's a reasonable endpoint. What should we be targeting? If you go back to the hydroxyurea trial that showed the benefit for hydroxyurea in ET patients, there was a post-hoc analysis that said, okay, in that trial, they started hydroxyurea to try to get the platelet count at less than 600. And when they looked back and said, okay, who are the patients that acquired the benefit? Was it the patients that got their platelets to less than 600? It wasn't. And so it didn't really matter that you got platelets to less than 600, it just mattered that you were on the hydroxyurea. The problem there is at that time that study was done, we didn't know that there was CALR mutations and there's different thrombotic risks. So some of this is difficult because it may be helpful to target a certain platelet count in JAK2 mutated patients. The biggest issue is that CALR has the least risk for thrombosis, but the highest platelet counts. In a lot of my patients, we're watching if you have platelets of 2 million, 2.5 million. They don't have acquired von Willebrand's, they don't have any bleeding issues, they feel great, they're CALR mutated. We've been watching them for 8 to 10 years, right, with no issues. But would I feel as comfortable with a JAK2 mutated patient at that platelet count? Maybe not. Absolutely. I think they're different diseases a little bit. I don't have a magic number. My thought is I'd like platelets to be normal if we can get them there on tolerable doses of cytoreductive therapy, but I'm not going to push them into discomfort to achieve a goal that I don't know if it's clinically relevant.
Absolutely.
And I think this number plays a big role for JAK2, but again, not for others, especially when we've been seeing some of these young patients who are very low risk disease and are asymptomatic. We could just definitely monitor as opposed to chasing that particular number.
Andrew, before we close, you mentioned the importance of allele frequency when looking at JAK2. You touched on this in PV, in ET as well. How frequently are you monitoring this? And clinically, is this helpful?
Not as much. At PV, yes. And if they're on interferon, because that's the goal of what we're trying to do, sometimes it can help with treatment decision making. It's just another variable you can factor in. So, you have, especially a young person who wants to do this to be proactive, and you have them on this, maybe they're tolerating it fine. You'll find out they're tolerating it better if they find out their JAK2 mutation went from like 60% to 20%. They're like, oh, actually, no, I do want to stay on this, right? And it may make you change doses of interferon rather than switch to a different agent. So I think it is a piece of the puzzle. We started doing it in interferon treated patients maybe every 1 to 2 years. Exactly when to do it, it's unclear. It depends on the patient sometimes. Ruxolitinib in the MAGIC PV study that came out recently also showed the ability to decrease JAK2 allele burdens over time. Median follow-up was like 4.8 years on that study. So no reason to check it frequently, but it's something that we may recheck. And certainly I'll recheck it if the disease looks like it's changing, right? Because you have these ET patients that all of a sudden now they're more erythrocytosis and maybe the spleen's grown and you check and look, the JAK2 allele burden's doubled. And we know that can happen. I think it is a piece of the puzzle. It's like the bone marrow too, right? Does everyone need a bone marrow? Does checking the JAK2 liver, is that going to change management on an individual basis? Maybe not, but I do like to know as much as I can about the disease when I'm making these decisions.
Andrew, thank you so much for covering this PV and ET in such a short time. For our listeners, let us go a quick recap from today's discussion.
In today's discussion with Dr. Andrew Kuykendall, we outlined the evolving 2025 treatment landscape for PV, Polycythemia Vera, and ET, essential thrombocythemia. We touched on different driver mutations, risk stratification, clinical presentation, and the individualized plans for aspirin, phlebotomy, and Cyto reduction for these patients.
For PV with low risk, we often rely on phlebotomy and aspirin, and in that rare population, cytoreductive therapy who cannot in fact tolerate phlebotomy or have excess leukocytosis, thrombocytosis can be rather critical, whereas cytoreduction plays a bigger role for higher risk patients. For ET, risk stratifying to guide observation versus intervention can be important. Before starting aspirin in a patient with high platelet count, make sure to exclude acquired von Willebrand disease.
Thanks for joining us. Check out our other hematology episodes, including challenging cases, treatment algorithms, and ToxCheck. We are the Oncology Brothers.